This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Now, how do you manage PC tear when you're doing manual small incision cataract surgery, which also has a vitreous prolapse? So let us try to learn few things from this case. Now, this is a 75-year-old lady who has this posterior cataract, and this surgery is being done in camp settings, so the charitable settings, and it is a planned manual small incision cataract surgery with a PMMA lens, which is a routine for these charitable eye surgeries. Now, of course, I was prepared mentally and to handle this case, as I was expecting a posterocapsular tear in this patient. So let's see how things turn out. I'm going to start the case after the tunnel is being done and the rhexis is being initiated. So the plan was to do a slightly oval rhexis so that I don't have to struggle while doing epinucleus and cortex removal. It has become oval all right, and of course I would not be doing any hydrodissection in this patient. I'm trying to do a mechanical dissection using an iris spatula. At least this reduces the adherence of the anterior equatorial cortex to the capsule. This is something which I learned from Dr. Arup Chakrabarti from Kerala, India many years back. So I'm not going to do any hydrodissection. No, I just try to do hydrodelineation. It's not possible in this patient because the nucleus is quite dense and I didn't want to try anything more aggressive in this patient. So with these things, I want to prolapse the nucleus out of the bag. Now, in this situation, because I'm anticipating an posterocapsular tear, I don't want the chamber to shallow or collapse when I prolapse the nucleus out of the bag and also when I extract the nucleus out of the eye. So for that reason, I'm using a sodium hyaluronate exclusively for this patient to prevent that one side effect, that is prevention of collapsing of the antechamber. So using 2 Sinskey hooks, the nucleus is gently maneuvered out of the bag, and so far so good. There isn't any evidence of shallowing of the antechamber. Again, the chamber is inflated with OVD. Using a vector center dialer, I'm going to grasp the nucleus in between these 2 instruments and carefully pull it out. There is a slight shallowing of the chamber in spite of using sodium hyaluronate, but at this moment there is already tear which is visible. But at this stage, I don't think that the vitreous has prolapsed still. So I'm hoping that I can extract the cortex and place the lens without vitreous prolapse. So I carefully go in with my Simcoe cannula and then aspirated the cortex from one segment. Now, because I'm not using the traditional bimanual I&A system which I use with my phacoemulsification, I find it very daunting to maintain the chamber. I'm unable to maintain the chamber, and as soon as I come out, there is always a collapse of chamber. And I don't have another side port through which I could have used an OVD, which I typically do with our phaco setup. There was one lack of foresight which I should have done. So this shallowing of the chamber could have been prevented by injecting OVD from the other side port. And it looks like there are 2 tears. One would be the posterocapsular tear, and the central round tear is actually the anterior hyaloid. It's very clearly visible that the edges of the posterocapsular tear are spindle-shaped and triangular, and these are at risk of running towards the periphery. So the best thing to do is to convert this tear into a posterocapsular rhexis so that I can still have the ability to place the lens into the bag. And I want to do it before doing a vitrectomy, simply because during vitrectomy itself I could enlarge this irregular posterocapsular tear. So eventually I had to make a second side port, and it would have been worthwhile if I had done this before itself. So I put in OVD so that if at all there is any vitreous, there is pushed back. I don't engage it with my forceps. Since the visualization is quite good because of excellent dilatation of the pupil, I'm very clearly able to visualize the posterocapsule, grasp it, and then initiate the tear into an circular tear and then complete the posterocapsular rhexis. So now I have a posterocapsular tear which is circular and round with continuous edges, and this is unlikely to run towards the periphery. I still feel that there is no vitreous prolapse, but I'm not sure. So I go back, inject diluted triamcinolone acetate, irrigate it, and still I'm not convinced that there is prolapse of the vitreous. But nevertheless, I would want to go ahead and do an antivitrectomy. I also need to clear these small lens debris or lens fibers which are there in the antivitreous. So the irrigation goes in through my left hand side port, and I'm introducing the cutter through the right hand side port. And please note that the position of the cutter before I started, it is positioned at below the level of the posterior capsular tear, at the level of this anterior hyaloid which is ruptured, and then the cutting is begun. The irrigation handpiece which is held is directed away from the posterior capsular tear, and the cutter is held behind. And I'm using the Alcon Legion phaco machines cutter. This is an electric cutter and it does a good job. We can see these little bit folds on the posterior edges of the tear, which might suggest that there could be some vitreous fibers around. Eventually, all of this is cleared in a matter of a couple of minutes. And now with a better visualization, we can see the clear demarcation of the posterior capsular rhexis. The most important message I would like to give is whenever we are suspecting any vitreous prolapse, the vitreous has to be dealt in first before removing the cortex. So that's what I'm doing now with the same cutter. The settings are changed to the cortex mode. I'm using the vitrectomy cutter itself, which is probe facing up. I'm engaging the cortex, stripping it, and then aspirating. The hands are switched. The remaining part of the cortex in the opposite quadrant is also aspirated out. So now we have a clear view. There's hardly any cortex left. We have a nice posterior capsular rhexis. There's no evidence of vitreous in the bag. And now is the time to place the lens. I'm going to use cohesive OVD to deepen the capsular bag, and then the originally planned PMMA lens is gently negotiated through the antechamber into the capsular bag. The distal haptic goes into the capsular bag first, followed by dialing of the trailing haptic into the capsular bag. I just want to ensure that both the haptics are horizontal and away from the area of the posterior capsular tear. Gently the lens is dialed to get into a desired position. A 10-0 nylon suture is used to close the main incision. Now with the irrigation and the cutter, I go into the antechamber, and the cutter is introduced behind the lens to go and aspirate all the OVD which has been pumped behind the posterior capsule. And once it is done, the OVD in front of the lens is also removed. Diluted triamcinolone acetate is used one more time to rule out any prolapse of a single vitreous fiber, and there seems to be none. Diluted pilocarpine is used. The side ports are hydrated. The conjunctival flap is closed using an atovicral suture, and the intracameral antibiotics are placed into the eye. To summarize, so the principles of managing a PC tear and doing an antivitrectomy would be similar in manual MSICS as we do it in our phacoemulsification. The only sometime the problem which could arise is if your scleral tunnel is not self-sealing, then there could be some leakage through the main incision during vitrectomy. If that is the situation, you should always go back and suture and then do bimanual antivitrectomy. Otherwise, the principles remain the same. Number 2, whenever we have an opportunity, it's better to always convert the posterior capsular tear into rhexis. Technically, it's not so difficult. The only thing is the consistency of the posterior capsule is much more thinner than what an anterior capsule is. And that's the major difference. Once you get the hang of doing in 1 or 2 cases, you know the feel and the texture of the posterior capsule, and then it would not be any more difficult than your anterior rhexis. Only thing is, have a good pair of forceps, keep the chamber formed with good viscoelastic, and then you should be good to go. So that was it. Thank you for watching and hope you found this helpful.